Thanks, everyone. You got quiet so quickly. Okay, so I want to welcome everyone to the final session of our conference. I'm sure it has been, I hope it's been a really great day and a half for everyone. Great. I sort of always love Sunday because, first of all, we're all a lot more casual, and you know, it's a more intimate group because there are people that had to leave. Yesterday was just a packed house, and I want to just, if you haven't thanked my staff and if you haven't had a chance to meet Kathy and Janine and Amy and Sharon and my entire team, I just want you to know they put so much effort into this, and please take a minute to thank them. It would just mean a lot to them. So we once again have a live web streaming audience, so we are not alone. And when we get to the Q&A, we will again be texting questions, and we will be taking them from both all of you in the audience as well as those that are watching live stream. So some of you just got to hear from Dr. Pallav Mehta, who were in the clinical trial workshop. I got to be in at the tail end, which was great. He's wonderful. We are so lucky not only to have him as a speaker today, but he is on our board of directors, which is great. And we're actually giving him an honor at our gala this year. So and I've gotten to attend and introduce him many, many times. So before we start, he has this amazing book that he might talk about called After Cancer Care. And we only have 2 copies today, although they can be bought in Amazon. But if anyone wants to buy these 2 copies at the end, and I have a pen, so he will sign them, run to the stage, and he will do that. But before I bring him up, because I know some of you need to run to the airport, I just want to really thank you all. And please remember, Living Beyond Breast Cancer is here all year round. We have lots and lots of programs for those living with metastatic breast cancer. Janine talked about our program on May 28th on genomic testing, which will be also live web stream. So while it'll be in Philadelphia, you can watch it from anywhere. May 8th, what did I say? May 28th, whatever. May 8th, and you know, we just have things that are ongoing. So please stay in touch with us, give us feedback. That's how we make our programs stronger. And Dr. Mehta is going to end this morning really talking about how to live healthier. So I'm going to bring him up.
All right. Okay, I had about 3 minutes there, so that was nice. Thank you. Thanks for having me back, and thanks. And I want to echo what Jean said about LBBC. They really do a wonderful job putting these conferences together. So thank you for that. And I want to thank the patients. Metastatic breast cancer patients make my job very difficult, and they make it very rewarding. My Friday afternoon office hours, I had 2 residents with me. That day we usually have students and residents and fellows. And I had about 18 patients. It just so happened that day about 12 or 13 were metastatic breast cancer. And so it was a difficult day. And by the end of it, one of the residents was crying and the other one was slumped over in the chair. And I went home and had a drink. But I love treating metastatic breast cancer, and hopefully I will continue to do so for years to come. So I wear 2 hats at my center. I am a breast medical oncologist, first and foremost, but I also head up a department called Integrative Oncology, which some of you have heard about. Many centers now around the country do have integrative departments. And we're going to focus on trying to use integrative approaches to symptom management and side effects. Now, obviously, we can't have an exhaustive discussion about this because there are so many issues that I think women are having because of their disease and because of the different treatments that we give. But I'll try to go over sort of the major ones that we see. This is, my wife hates when I put this up here. But this probably sums up at least half of the side effects that we see from breast cancer therapies. and obviously it's a funny slide, but when we treat a lot of our breast cancer metastatic patients are younger, and most of them are either become menopausal because of chemotherapy, or we make them menopausal because we need to give them other treatments. So this can actually be a very difficult thing, as we'll kind of talk about. So breast cancer therapy has changed a lot over the years. There's been a lot of progress. That photo on the left, I don't know if anyone recognizes, that is one of the giants who walked the earth in cancer. That's Sidney Farber, who the Dana-Farber Cancer Institute was named for. So the sort of very loose connection I have with Sidney Farber, so in the early 40s, he was doing work on a drug called aminopterin. And he realized at the time that using antifolate therapy would help treat leukemia. But at the time, he was sort of a pariah because the prevailing notion was that leukemia, particularly he was dealing with childhood leukemia, kids with leukemia should be allowed to die in peace, and you don't treat them because all the treatments that were tried before just led to worse quality of life in the weeks that they had left. So he said, no, there's something to this drug, and ultimately aminopterin was then developed. A sister drug was developed right around that time called methotrexate. So flash forward about 60 years, so about 7 years ago, I get a call from my sister-in-law saying my niece at the time, who was 14, was having joint pains. And I said, well, she's 14, it's growing pains, so just give her, some Advil and she'll be all right. And then a couple weeks later, she was getting more tired and she was bruising. And I said, she's got her period now. She's probably iron deficient. Just get a blood count. We'll give her some iron. She'll be fine. So that Monday, and I remember it very well, I get a call from her saying, we're driving to the oncologist's office because Sophia's blood count was 125,000, which I knew immediately what that meant, and that she had an acute leukemia. So we embarked on this massive treatment protocol, lots of different drugs and various treatments. And about 6 months into it, she had 3 months into it, had a repeat bone marrow biopsy to look to see if the cancer was gone. And unfortunately, there was some evidence of cancer there. So in leukemia, that's a problem, because if you still have cancer left at the end of treatment, survivals are definitely very limited. And so she was at Children's Hospital right here, got her on a clinical trial. So again, the benefits of clinical trials. And one of the arms was utilizing high-dose methotrexate. And she responded to that. It ultimately had to have a bone marrow transplant. And today, she is a sophomore in college and doing great. Yeah. But thank you. And I mention that because, number one, standard therapy is important. So when I talk about integrative medicine, I want to be clear that we're not talking about alternative medicine. There's a lot of stuff out there that's unproven, sometimes dangerous. And I have patients that will see me. I saw a patient this week who didn't want to pursue any of the standard approaches after surgery for her cancer. 2 years later, unfortunately, she has metastatic cancer and still has a lot of reluctance. And I can understand some of that reluctance because of the treatments, but understand that standard therapy is really important. And it should be an important part of treatment for cancer. So in breast cancer, as you can see, lots of changes. William Halsted, radical mastectomies, modified lumpectomy. MD Anderson is about to open a trial, probably in a few months, looking at a non-operative approach to HER2-positive breast cancer. Whole different paradigm. You give women chemo. If the tumor shrinks and looks like it's gone on MRI, we then do a couple of biopsies and then watch. This was anathema 10 years ago. Radiation has changed a lot. Where proton therapy, there's still not a lot, but there's There's a few centers, one right here in Philadelphia. And certainly systemic therapy, mustard gas was the original chemo, all the way to immunotherapy now. I sent a patient to Sloan Kettering for a CAR T cell study recently looking at these chimeric T cells, and it's a whole new approach to cancer therapy, so it's really exciting. But with this approach, there come a host of side effects from treatments and the disease itself. And it's important that as oncologists, we recognize that, because I think the oncology community does a great job trying to further the research and progress in the treatment of breast cancer. But I think sometimes there's a feeling that if we're treating the patient and we're treating their cancer and we're helping them from a cancer standpoint, then that's good enough. And I think patients sometimes, particularly patients with metastatic disease, sometimes almost feel a little guilty in mentioning that they're having problems if their cancer is doing well. They should feel good enough that their cancer is doing well and not worry that, oh my goodness, I have all these side effects and I'm going to complain to my doc about these side effects. So I think side effect management's important. So women come through all these therapies, and all of you look like this after coming through all your treatments. You're happy, you're doing all these great things. But obviously that's not the case. This is more the case. So you get all sorts of problems. Fatigue and nausea and anxiety, depression and neuropathy and a host of issues. And there are all sorts of drugs out there. Some of these are very effective. Some of these are not so. I can look at the antiemetics as some real progress in cancer therapy. I remember when Emend came out, probably about 10 years ago, completely revolutionized nausea and vomiting with certain chemotherapy drugs. So there's real, again, standard therapy has its place, and I want to emphasize that. But it's hard to be on so many different pills. So in 2014, the Society of Integrative Oncology published their first ever guidelines on the use of integrative therapies in breast cancer. And just a couple months ago, they were updated in 2017. So 9 databases, over 5,000 publications over the last 25 or so years were used. And these are some of the big centers around the country. Sloan Kettering, MD Anderson, Columbia, but also integrative centers, the Ottawa Center for Integrative Studies, the American College of Traditional Chinese Medicine. So this was a nice kind of, I thought, a nice partnership between sort of the pure academia world and the integrative academia world coming together. Now, the issue that this study highlights, this is an actual study. It was in the British Medical Journal. It's meant to, obviously be facetious. So it's parachute use to prevent death and major trauma related to gravitational challenge. So, British humor being what it is, if you can't read the bottom there, but they say that we think that everyone might benefit if the most radical protagonists of evidence-based medicine organized and participated in a double-blind, randomized, placebo-controlled crossover trial of a parachute. My point in putting this up is to say that lack of data is not equate to lack of benefit. So remember that. So just because we don't have the evidence doesn't mean something doesn't work. It has to be tested. So part of the SIO guidelines is to make sure that we get the right amount of evidence out there. So what they are looking at is really just what's out there now. So in the next 5, 10, 20 years, you're going to see a lot more evidence about integrative treatments. We're seeing more and more in our standard journals now about whether it's vitamin D or acupuncture or massage or whatever. We're seeing a lot of interesting studies come out in our more sort of standard medical journals, which was not the case even 5 years ago. So different modalities that they talk about. This is how I sort of break it up. There's lots of ways to break up integrative therapies. There's mind-body approaches. There's natural products, which we'll talk about. And there's whole system approaches, which is, I think, more of a conversation for a different time. There's active therapies and there's passive therapies. Active therapies are things like meditation, requires engagement from the patient. Exercise is obviously requires engagement. Passive therapies, music therapy, acupuncture. These are more passive, so where the patient is having a treatment performed upon them. Supplements. Everyone knows about supplements and the word of caution about supplements. So remember, supplements are not regulated by the FDA. So, every day I have patients saying, well, which brand of fish oil should I take? And we purposely do not sell anything at our center because I don't want to be involved in that conflict. But there are hundreds of brands out there, so it's hard. How do you know what's good, what's not? You can't really ask your doctor about it because the doctors don't know. That's not their specialty. So, but these are 4 certification companies. So the USP is the one a lot of folks know. It's the U.S. Pharmacopoeia, National Science Foundation, NSF, Consumer Lab, which they have a good website, consumerlab.com. You can just click on companies and see if they tested them. And then UL, I forget what they stand for, but they're a newer player on the market. But if they have these labels, you don't have a guarantee of safety or efficacy. What you have is a reasonable guarantee that what's on the label is what's in the bottle. And you have a pretty good guarantee that there's no toxic contaminants or something more dangerous in the product. And then exercise, I want to mention exercise. It obviously helps in so many different arenas. I was a personal trainer before I was a physician, so I'm a big proponent of exercise, and I talk about exercise a lot to my patients. Obviously, it can help with everything. There's data on anxiety and neuropathy and pain and everything. But I want to, in the metastatic population, we do have to be a little more cautious. So exercising in a patient who had an early stage breast cancer, who had a lumpectomy, radiation, and is now on tamoxifen is a little different than a woman who's been through 4 lines of therapy for HER2-positive disease and maybe has multiple sites of metastasis. So just understand the blood counts. I think this is an important thing. Understand what an absolute neutrophil count, less than 500, a platelet count, less than 50, hemoglobin, less than 8. Those are situations where maybe you don't want to go to the gym. Doesn't mean you can't move and doesn't mean you can't do things, but you want to be cautious. Make sure your electrolytes are okay. Low electrolytes can be the cause of a lot of problems related from mentally and physically. Make sure you're hydrated. Understand bone metastases. So not all bone metastases, when you think of bone metastases, you think fracture. That's absolutely not the case for the majority of bone metastases, but understand if you have one that is at risk of fracture. Talk to your oncologist about that. If they're worried about a spot in a weight-bearing area that they think could, potentially put you at risk, you don't want to do high-impact exercise. It's not the time to be jumping up and down. Radiation skin changes. So radiation does cause some skin fibrosis, so stretching, for example, a lot of women who've had chest radiation, stretching the upper extremity, you want to be careful. You can actually cause skin tears. And then neuropathy, and if you've had treatment for brain metastases, there can be an impact on balance, and so risk of falls, coordination, proprioception, which is this idea of knowing where your limbs are in space at any given time. All of those things are affected. And a lot of women get blood clots with metastatic disease, so many are on blood thinners. So again, just to be cautious, it's not that you can't exercise, it's just understand that there are some potential limitations. So I'm going to go over sort of probably about 6 or 7 different ones from a symptom standpoint. And Calvin Hobbes is my absolute favorite. So you're going to see a lot of photos of Calvin. So anxiety and stress. These grades, by the way, are from the SIO, Society of Integrative Oncology. And if you Google it, you'll find their paper. It's readily available in PDF. So a grade A recommendation, so the A, B, and C recommendations are the ones that show that there's probably A means, benefit and good research that shows benefit. C means there could be a benefit. There's just not enough research. Remember, again, it doesn't mean that C is less beneficial than A. It's just about the data. So mindfulness-based stress reduction, that often goes under the sort of rubric of meditation. But for those who have either YouTubed mindfulness, which you can, and they have some really good 15, 20-minute mindfulness sessions that you could do on YouTube, it's different than meditation. I think a lot of us have a hard time meditating. Sitting in a room, dark room, and focusing on a candle for half an hour is hard, especially when you are thinking about a million other things with your disease. Mindfulness is more of an awareness of your own physical presence, of the environment, and your own thoughts, and understanding that these are all transient, and even 5 to 10 minutes of that awareness can really can impact anxiety, or as it's been shown. CBT is cognitive behavioral therapy. Many centers now have behavioral health departments. We do at ours, and they are lifesavers. In fact, we're hiring a couple more because there's such a need. Music therapy and yoga have been shown in good, smaller trials to have a benefit. And then acupuncture, you'll see, pops up a lot in many of this. Acupuncture has benefit in many different side effects. Does it have a benefit in cancer itself? No data yet that shows that, but definitely from a side effect standpoint. So again, talking to an integrative center, finding someone who is certified by the right organizations, the NCCAOM, I forget what that stands for, but the OM stands for Oriental Medicine. Natural products. So there are a lot of natural products that are purported to help with anxiety. Kava was one that came out in the late 80s, early 90s, and in a randomized study, it was actually shown to be at least as good as benzodiazepines like Xanax, and so everyone got really excited about Kava. It's not that it's not to be used in medicine. I say not recommended here because of metastatic disease. There's been several reports of liver toxicity in the past few years. We don't know which patient would get liver toxicity and which wouldn't. So at this point in metastatic disease, it's not really recommended, but it is one that's still on the market. These others, chamomile, lavender, lemon balm, passion flower, all have anti-anxiety properties. Exercise, as I said, is going to pop up. 20 minutes of exercise, we all know the benefits of the endorphins of exercise. And I should probably say physical activity rather than exercise, because it's not about a formal thing. It's about just being more active than you normally are and getting some moderate level of exertion. That counts as exercise. So 20 minutes of exercise can help. Eating breakfast sounds like such a simple thing. Now, not the donut and coffee that I had yesterday, but a good breakfast. One that has fiber, one that has protein. For the average woman who does not have any major gastrointestinal issues, 7 to 10 grams of fiber and about 15 grams of protein in the morning are a great idea within about an hour or so of waking up. The breakfast thing actually is because of insulin. So if insulin drops too far, it kind of does a lot of this all day, and that really affects a lot of things. It affects energy, it affects mental health. So trying to regulate insulin seems to be important. With anxiety, depression and anxiety are distinct things, but they often are found together in a lot of our patients when you truly test them. Again, mindfulness does come up here, not surprisingly. PMR is progressive muscle relaxation, which again, it's amazing how much you can learn on YouTube for free nowadays. But progressive muscle, PMR with guided imagery or without guided imagery can be really helpful. That's a grade A recommendation. Massage and yoga come up here again. Acupuncture gets a grade C, but there is more and more evidence with acupuncture now kind of moving up on the clinical trial scale. So I'll bet in their next update in 3 to 5 years when they do the update, there's going to be, some of these things are really going to be moved around. Natural products. So St. John's wort we've heard about for years. You do have to be careful. If you look at the list of interactions with St. John's wort, there are a lot of potential interactions. So be cautious. This is one where a lot of docs are aware of St. John's wort, and just understand what restrictions you might have with certain drugs. For example, blood thinners particularly. SAMe is S-adenosylmethionine. And there's been some good studies that have shown benefit in depression. Now, again, not so much in anxiety. And what are these happy foods? So fish, not to be eaten all together, by the way. Don't put it in your Vitamix and drink it. Yeah, I know. You'd be surprised at things I hear, believe me. So fish is because of the omega-3s, omega-3 fatty acids, particularly EPA, seems to have some particularly DHA seems to have some benefit in terms of mood. Sour cherries, so why sour cherries and pumpkin seeds? Those two have a lot of tryptophan. And so tryptophan is the precursor to serotonin, which is our sort of happy hormone, so it crosses the barrier, and theoretically you feel better. Exercise, again, from a standpoint of depression, there are good randomized trials on exercise and depression that show benefit. The old hot flash. Yeah, these are tough. Hot flashes, night sweats, sort of in this general category. The acupuncture here really has shown benefit, and I will refer patients to a licensed acupuncturist for refractory hot flashes. There are standard therapies, which, by the way, standard therapies for hot flashes are good. So there are drugs like Effexor, which doesn't have a lot of side effects and can really help with hot flashes. But yoga has been shown to help, and of course, weight loss, which is so easy for everyone. But weight loss is, so the idea is that you theoretically have your fat cells harbor the enzyme aromatase. Aromatase is the enzyme that converts testosterone to estrogen, so to speak. So the more fat cells there are, the more estrogen there is, and there can be more hormonal symptoms. There have been lots of natural products looked at for hot flashes. Black cohosh is one that comes up all the time. Some recent studies with black cohosh were a little disappointing. So we don't know so much if it really does. It's still a potentially effective option. It's available, readily available anywhere. Dong quai is an herb that you can get in supplement form anywhere. These two are the sort of possibly effective from a guideline standpoint. Again, we have nothing that is definitely effective, because if I had something I could give that was definitely effective, I wouldn't need to work anymore. So EPA, so if you think of the omega-3 fatty acids, so there's the essential fatty acids, omega-6, there's omega-9, which is not as relevant to this discussion, omega-6, omega-3. Omega-6 are the pro-inflammatory fatty acids, omega-3 are the anti-inflammatory fatty acids. Omega-3s, you divide them again, there's long chain and short chain. Long chain omega-3s are what you find in the vegetarian sources, flaxseed, chia, pumpkin seeds actually have walnuts. Long chains are not the ones we're talking about here. Long chains, your body has to convert them. They have other value, but in terms of when we think about the benefit, particularly in some of the symptoms we're going to mention, in hot flashes, EPA is one of the EPA and DHA are your two short chain omega-3s, and EPA seems to have benefit in hot flashes. So I do recommend fish oil or krill oil. It so happens the difference, people ask what's the difference between krill oil and fish oil. Well, they're relatively similar, except krill oil has more EPA than fish oil does. Fish oil has a little more DHA, which in the general sense is not that clinically relevant, but EPA is one that's been shown in hot flashes. And then red clover, people have talked about it, evening primrose oil. It does not appear that either of these are that effective. Soy. Soy is something that comes up a lot in breast cancer, and I think it's a big conversation. We could have a talk just about soy. The simple answer, and something recently just published just a month ago, again, soy is safe. Soy is safe to use. The studies show that soy is okay to have in moderate quantities. There was some old data that showed that maybe there's some increase in vitro of estrogen positive cells. Soy, the concern was that soy has a phytoestrogen, a plant estrogen called genistein. But when you really look at the studies, and this was a large study done somewhere in New England, I forget where, but sort of following women for long periods of time. And again, once again, confirmed some of the Asian studies that show that not only is it safe, but for example, in early stage breast cancer, it may actually decrease risk. It's not to say to go out and have tofu 4 times a day, but if you were somebody who liked tofu or had soy milk, or it is safe to use. And I want to emphasize that. Nausea. So nausea is one of those that is can be a more rapid side effect, although some women have chronic nausea depending on their sites of metastasis. But nausea is one where you really do need to understand where it's coming from. So there's gastrointestinal sources of nausea, and there's central nervous system sources of nausea. So understand the difference, and make sure that your treating team is not always just chalking up the symptom to chemo. Often, chemo can be the culprit, but nowadays with a lot of the good drugs, like I mentioned, like Emend and Zofran, we don't see as much vomiting as we did even 10 years ago, and nausea is a lot better. So if someone is having refractory nausea, just make sure that your team has a reasonable understanding of what's causing it, because different sites can mean different things. So officially speaking, there's no grade A recommendation. However, I think this will definitely change because ginger down there, there was randomized trials in women on chemotherapy now taking ginger supplements and showing a definite benefit to nausea. So that I think will change on the next go around. Citrus, is anyone who's had a tequila shot knows this is why it helps. It actually has some central. Not that maybe Friday I did, I don't know. And then clove and aniseed both have natural anti-nausea properties. I can remember when I was young, my grandmother, of Indian descent, and my grandmother, along with the turmeric and almond milk that she would make me drink as a 10-year-old, was not pleasant, but I did. She would also, anytime that we had nausea, we would actually chew on a whole clove. And yeah, again, as a child, not pleasant, but it does take away nausea. Maybe causes other things. And then the meals. When it comes to nausea, nutrition is so important. So eating small meals, bigger meals, when you stretch that, when your stomach, when the rugae, the lining of the stomach starts to stretch, nausea absolutely gets worse. So smaller meals, don't stretch that stomach lining too much. Greasy meals tend to increase nausea. Spicy meals, possibly in some people, particularly if they're acidic, spicy. And then even the temperature. So if things are too hot or too cold, that actually can precipitate more nausea. I didn't mention in here, but bowel function can cause nausea. So if your bowels aren't great, you're going to be more nauseated. So making sure that you are aggressively managing, because a lot of patients with metastatic breast cancer are on pain meds, which cause constipation, and being very proactive about constipation is important when you're on, particularly on narcotic-type pain medications. Tiredness, fatigue. This is a tough one because everyone's tired. And patients with breast cancer are tired for different reasons. Patients on hormonal therapy are tired for other reasons. And then people are tired just because they're tired. But why? But what are the so chemotherapy causes fatigue. Sometimes it causes fatigue without causing a blood count problem. So just chemo fatigue can happen when people's hemoglobin is 13. So just remember that. But anemia is something that we see. Don't assume that anemia is only because of chemo, because I can't tell you how many times I've seen patients whose anemia is from iron deficiency, whose anemia is from another condition that they didn't realize they had, an autoimmune condition, from a B12, whatever it is, but a thyroid deficiency. So make sure that your oncologist or your treating team is maybe checking up on that. You can always just ask them, hey, can we just check my iron studies or my B12 or my thyroid hormone? Because I'm really feeling extra tired and I didn't, this is not something I expected or whatnot. Integrative therapies in fatigue are tough because, again, it depends on what causes the fatigue. But hypnosis has actually been shown to help with fatigue. And again, acupuncture comes up here. There's not a lot of natural products that seem to really improve energy, but Panax ginseng has been studied. There's American ginseng and Panax ginseng. Siberian ginseng apparently is not real ginseng. I don't know why. The ginseng community is up in arms about that, but Panax and American. So Panax ginseng has been shown to improve cancer fatigue. And this is again where small meals, fiber, low sugar, simple carbs because of insulin. So as insulin does a lot of this all day, you are guaranteed to have energy ups and downs. So eating every 3 to 4 hours, after about 4 hours, your insulin levels, your body's glycogen stores get pretty much used up, and all of a sudden insulin starts to fall. And so that's the idea behind the every 3 to 4 hour eating. Sleep hygiene is important, which I'll talk about in a second. But having routines and trying to get to bed, I mean, it's easier said than done, of course, but getting to bed around the same time, getting up around the same time is important. And so that leads us to insomnia. So sleep hygiene really, it's amazing how much insomnia is actually caused by that alone. Just making sure it's the simple things, making sure the bedroom is a bedroom and not, is a relaxing place. Technically, no TV in the bedroom, although I certainly have a nice one in our bedroom, but technically, you're not supposed to have one in there because, everyone knows about the light issues. So iPads and iPhones and all those things that even in night mode, which now the newest iteration has night mode, it will stimulate hormones from the pineal gland that keep you up. So I tell the kids, I have a 15, a 12, and a 9-year-old who all have their devices, and they all do not get to take, well, no, my 15-year-old's allowed now, but the others are not allowed to take them in the room at night. But temperature, 68 degrees seems to be the ideal temperature. So the idea is not that you have to set your room to 68, but that warm rooms are not conducive to sleeping. Cooler temperatures seem to be better to induce sleep. Yoga, so you don't want to have a heavy workout at night because that has absolutely been shown to cause sleeplessness. But yoga at night actually can induce, and a slower yoga. So there's hot yoga and all these different types of yoga, but a more gentle breathing, heavy yoga. Natural products, melatonin, I think is one that gets a lot of press, but the real studies in sleep are very low doses. I've seen patients take 20 milligrams of melatonin. It's not really recommended. There was some potential anecdotal evidence that it may help with cancer, but we're not there yet with melatonin. So for sleep, it's low doses. The actual study was 0.3 milligrams for sleep. And this is the tryptophan issue pops up here again. So it seems to be, and this is interesting, that when you have a small amount of carbohydrates before you, like a little bowl of cereal, for example, the insulin response that you get diverts most of the amino acids to other things. So tryptophan is kind of unchallenged getting through your blood-brain barrier. So the blood-brain barrier is this evolutionary barrier that exists to prevent all the crap from our blood getting into our brain. It also prevents a lot of treatments from getting into the brain. But tryptophan can more easily and readily access the blood-brain barrier if you have a little carbs beforehand and you have a little insulin. Because tryptophan is not affected by insulin, so it can now kind of free and clear cross the blood-brain barrier, turn and help with sleep. Valerian is a root that has been used as a tea that's been shown to help with sleep. Neuropathy is one that we see a lot from a lot of our chemo drugs. So taxanes, platinums, lots of drugs cause neuropathy. The blood sugar thing is interesting. So you don't have to be a diabetic to have a hemoglobin A1C that's 6.0. And a lot of times, once a patient has metastatic disease, the primary care doc kind of falls out of the equation, as many of you may have noticed. And so the oncologist becomes the de facto primary care, which really, yes, we are internal medicine trained, but I finished residency 13, 14 years ago. I don't remember how to treat diabetes. So it's important to check, if neuropathy is happening, have your doc check an A1C. Because getting it under 5.9 seems to actually be helpful in managing I'm talking about non-diabetic neuropathy. Diabetic neuropathy is a whole other thing. If you have diabetes and you came into treatment with diabetes, then definitely A1C management is paramount. But then you have medications that you can take. This is from a dietary standpoint. Alcohol, minimize it. Although there's some reports, my father has an idiopathic neuropathy, horrible idiopathic neuropathy. Every time he has a drink, he feels better. Maybe he's just telling me that. But then I looked it up because I said, this doesn't sound right. But apparently there are reports of people having, or maybe he said every time he has 5 drinks, he feels better. I don't know what it was. Acupuncture has definitely been shown to help massage, oncology massage. And remember, massage and oncology massage are different. You want someone who is trained to manage patients with cancer, particularly when you're talking about metastatic disease. You don't want to cause harm. So oncology masseuses have extra training and certification and licensing. Progressive muscle relaxation. This list of supplements. So we actually, at my center, now I have my patients, so there's a list of a couple of these, I'll mention which ones, but that they take if they're on Taxol. And I haven't yet put it into context of a clinical trial, just because, as we mentioned earlier, regulatory issues with clinical trials are difficult, and it's been hard to kind of put it together. But I do recommend vitamin B6, alpha lipoic acid, these two, and I usually put people on fish oil. And again, absolute anecdotally, I have seen less issues with neuropathy in my patients. But again, I want to put it in the context of a study, hopefully. And acetylcysteine is another one that's been shown to help. Glutamine actually is supposed to be is great for neuropathy, but you can't take it with certain drugs, taxanes particularly. But if you're not on a taxane, glutamine is safe. Acetyl L-carnitine is one that initially was shown to be helpful, but then actually a randomized trial showed it may worsen neuropathy. So that's probably not a good idea. And capsaicin cream is a topical cream that you may have heard of. So there's a difference between the numbness and tingly neuropathy and painful neuropathy. Those are different mechanisms. The drugs like Neurontin and Lyrica and all those neuropathic drugs do not help with the numbness tingly neuropathy. They only help with painful neuropathy. So if your doc is giving you Neurontin because you've been complaining of tingling, it's probably not going to do much. Just FYI. And then pain in general. Again, a tough one, because pain, you want to know, there's a whole field of integrative pain management. It's a whole separate world of integrative therapy. But it's important to know where this pain is coming from, because there's so many different types of pain. Like we said, neuropathic pain, there's visceral pain, there's acute and chronic pain and the management of it and the various types of meds. The pain industry in the allopathic sort of standard of care world is a multi-billion-dollar industry. Low back pain is the #1 complaint that people go to their primary care doc for. So pain is a big deal, and certainly in metastatic cancer, pain is a big deal. Bone pain is different from organ pain, and the treatments for it are different, and the underpinnings, the physiologic underpinnings, are different. So understanding etiology, I can't overemphasize how important it is to understand the etiology of pain and where it's coming from. Again, just like neuropathy, acupuncture, well studied, as is oncology massage. So as you can see, some of these recurring themes, if there is an integrative center connected to your institution, or one that your institution may recommend because they don't necessarily have the resources to have one, really it's not a bad idea to talk to them. I want to mention in particular joint pains. So the AIs are the aromatase inhibitors, which many in the room are probably on, or some in the room are on an aromatase inhibitor. Joint pains are the most common side effect of aromatase inhibitors. And every single patient I start on an AI, I also start on these 3 things. And the first 2, there is good randomized data, recent, a year ago. There was one study looking at vitamin D in aromatase inhibitor-induced arthralgias, and a study looking at omega-3s. And both were found to significantly reduce the intensity, frequency, severity, et cetera, of joint pains. Omega-3s, I recommend that a lot of my patients take fish oil. Just remember that the dose of the fish oil is not the dose of the omega-3. So look at the bottle. Fish oil, 1,000 milligrams, could have 200 of omega-3. It could have 800 of omega-3. The more expensive ones have more. But just know, again, understand the label of the bottle and what it's saying, because the dose that I recommend is about 2,000 a day of omega-3. In Europe, for rheumatoid arthritis, they use about 3,000 to 3,500 as a treatment option in Northern Europe. Vitamin D is another one that comes up in cancer, particularly in breast cancer. Often you'll have a vitamin D. If your doc is checking vitamin D levels, great. If they're not, check them. The level that you want to, that seems to be optimal is about 40 to 60. So not just a normal. Normal's 29 or above 29 is considered normal. 40 to 60 is where you really kind of want to be. And when you get to that level, often that's when you start experiencing some benefit from a joint pain standpoint. So pushing up that D dose. It's very hard to get the dose of omega-3 and the dose of vitamin D from food and from the sun. You can't. Particularly in metastatic disease where you're on therapies and other, often absorption of things is not good. And so this is why I do recommend that as a supplement. Curcumin is the active ingredient in the Indian spice turmeric. So sure, you can put turmeric on things, but it's a potent taste. You can put it in your almond milk if you'd like. It's actually a little easier to take it as a supplement. And I am not a proponent of adding pills to people's regimen, particularly with metastatic disease. And I want to be clear about that but if we're having symptoms and if you're on an AI, these things really do help, these three things. So just remember the foundation of a lot of this: eating right, exercising. I know these are very generic recommendations, but I can't tell you how important they are. So I see time and time again people who don't eat well. I had a woman a few months ago who was drinking 12 cans of soda a day. Yeah, I don't know if she had time for anything else. But she had lots of issues, lots of symptoms and things, not surprisingly. Exercise, again, physical activity, safe physical activity. The American Council on Exercise, which was the body I was certified through, and the American Council on Sports Medicine have cancer certifications for their trainers. So you want to seek out somebody who understands. You don't necessarily want a meathead who's going to have you do boot camp, Although maybe boot camp's your thing. I think it's Gene's thing. Yeah, right. And stress reduction, which, I think we throw that around as if it's so easy to do. And I think for many it's hard, and certainly when you're going through what a lot of you are going through, stress reduction is not simple. But making active attempts to try and pursue reduction in stress is important, and that you can do, which, we talked about some of these, whether it's mindfulness or music therapy or, social support and seeking out social support and being part of a group that you enjoy and get something out of. That's important just from an overall symptom standpoint. These are some resources. Society of Integrative Oncology. The National Center for Complementary and Integrative Health is the relatively new name of the organization. It used to be called the National Center for Complementary and Alternative Medicine. Again, alternative is taboo, so that got taken out by the Obama administration. We'll see what the Trump administration does to it. Sorry, I promised I wasn't going to say anything, but MD Anderson has a great website. Sloan Kettering's supplement database is second to none. Every supplement under the sun, or not every, but almost every supplement under the sun, and they have a patient section and a healthcare provider section. So, which I love, because I think for all of us, me included, I often refer to those when patients are on things and I don't know what it might be. They have the studies, they have the links. It's great. So MSKCC. And then a couple of these others, which are actually endorsed by the SIO guidelines, naturaldatabase.com, the American Botanical Council, and then Natural Standard. These are evidence-based places to get information about integrative therapies in health in general, but definitely in cancer as well. So thank you for your time. Thanks everyone for coming out and for supporting this great organization. Hopefully this was helpful. Thank you.
Thank you so much, Dr. Maida. So we're going to be putting up the text number, and while we're polling for questions, we do have a couple. This one's a quick one. On your slide about vitamin D, 40 to 60 of what?
Oh, sorry. The level of 40 to 60. So when you check a vitamin D level, that should be your level, 40 to 60. So I think it's, I don't know, I think it's micrograms per deciliter or something, but that's the level you want on a blood test.
Great, thank you. Our next question is, I have chemotherapy fatigue and find it difficult to exercise with regularity. What do you recommend as to the type of exercise to try?
Yeah, and certainly it's a broad question. There's definitely, and this is why I mentioned this issue of exercise and sort of your own rate of perceived, there's something called RPE, rate of perceived exertion. So the RPE is different for everyone. So marathon runners can go 2 miles and not feel a thing. I run 2 miles and I need my inhaler, So everyone's different. And so understanding that exercise and physical activity are sort of individual. Yoga is a great exercise to do. Depending on how it's done, you can get cardiovascular benefit, you can get resistance benefit, bone density improvements, muscle building, and it's safe. So partly it's understanding the exercise and doing it slow and controlled. With metastatic disease, high impact in general, generally not recommended, but depending on the situation, it can be.
Next question is, how do you increase your electrolytes if your electrolytes are low?
Yeah, good question. So you can supplement with them if they're low. So if your oncologist, depending on the treatment you're on, so if you're on chemotherapy, your oncologist is checking these things very regularly, usually every 2 to 3 weeks. You're getting blood work that's showing what your potassium and sodium and calcium and magnesium are. If they're not, if you're on a hormone therapy, often they're checking it every couple of months. So understanding that if your potassium is low, very easy, and just take a potassium supplement. You could increase your intake of foods that have certain things in them, but if it's, depends on how low it is, but if it's really low, a supplement's a very easy thing to do. And there's supplements for magnesium and potassium and all sorts of things.
Thank you. Our next question is, what do you recommend for people with metastatic disease who experience problematic weight loss? Are there particular integrative methods they can use to help them with their weight?
Yeah, so first understanding, is the weight loss happening because their appetite is diminished, or is the weight loss happening because they're eating normally and they're losing weight? So those are two different things. So if your appetite is down and then that's why you're losing weight, then there are things you can do to increase your appetite. There is a prescription for a liquid called Megase, which actually can help a lot of folks. Medical marijuana, which I did not mention here, but I think has a lot of value in a lot of this stuff. There's actually interesting evidence in a lot of this stuff. Medical marijuana, there is a synthetic version called Marinol, which doesn't seem to work as well, but can absolutely stimulate your appetite. If you're losing weight because you are eating and still losing weight, that's often a function of the cancer itself, and usually in that setting what happens is the treatment of the cancer helps improve appetite. But if that's not happening, and again, usually if that's the reason, it will improve appetite. But if that's not happening, then shakes are a great way to get calories. You don't feel like eating often when you don't feel good. So if you don't feel like eating, you can still drink. I don't want to necessarily promote one brand over another, and I don't have connections to anything, but Orgain is a brand that I've seen a lot, and a lot of my patients are using. I'm not a huge fan of some of the standard ones that are out there because there's a lot of chemicals and a lot of sugar, but there are brands out there. Look for cleaner brands of shakes, or make your own. If you can invest the funds in a high-quality blender, there are some great recipes you can do to your liking. And this is not about green drinks. Remember, the green drinks are not going to help your caloric intake. This is about a supplement, a meal supplement. So that involves higher calorie foods that are, in a liquid form.
Great. Our next question is if you could comment on integrative methods to use for chemo brain or cognitive function problems.
Yeah, that's a tougher one. So a couple of the supplements that I mentioned for anxiety and depression can help. Chemo brain is something that we are we have been studying for a long time. And to this day, there still is no consensus on what causes it. There was a study that said it's anxiety. I mean, if you ask women who have chemo brain, they will tell you it's not just anxiety that's causing chemo brain. There's something else to this, and we don't know if it's a function of some of the chemo drugs that we're giving. We don't know if it's a function of some of the hormonal treatments that we're giving. I don't think there's any one supplement that's going to help improve chemo brain, but again, the issue of diet and exercise and just general health has been shown to help. Actually, there's one exception of it, the fish oil, the DHA. There was a study about a year or two ago that showed that maybe there's some benefits. So since I recommend a lot of the omega-3s, DHA, which you see infant formula is DHA fortified, it's for neuronal development, can help.
Thank you. Next question is about caffeine. Should we be avoiding caffeine to manage hot flash symptoms? Is there any connection?
Oh God, don't avoid caffeine. It's so important. My goodness. Yeah. No, you don't need to avoid caffeine. So less than about 200 milligrams a day seems to be okay, even up to 300. But if your hot flashes are really just nonstop, lowering your intake can help, and potentially getting it from other sources. Caffeine from green tea versus caffeine from, it's still caffeine, but it seems to be that the other compounds in green tea may help with hot flashes a little more than coffee would. But no, minimizing it's important. It's not really going to change things if you completely stop all caffeine.
Thank you. Mm-hmm. So we're getting lots of questions about the appropriate dose of curcumin and vitamin D.
So the curcumin is 500 to 1,000 milligrams. Vitamin D, it's not about the dose, it's about the level. So that's why it's important. Just have your doc check a level. There's patients that tell me, I've been taking 5,000 units for 3 years, but no one's checked the level. So it's like taking a blood pressure pill and not checking your blood pressure. So just, again, it's not about the dose. Some people need 50,000 once a week. Other people barely need 1,000 a day, and they're fine.
Our next question is about cannabis oil. Are there any benefits for stage 4 cancer patients?
Yeah, this is a controversial issue. I have patients that thankfully are honest with me and are doing it. In California, there's places that have more theoretically regulated facilities that claim to have their own data about it. At this point, we just don't know if cannabis and its chemicals help with cancer. There's definitely benefits in terms of side effects, so appetite, nausea, anxiety, pain, neuropathy, a lot of the things we mentioned. But from a cancer standpoint, and partly, again, it's the lack of data is not lack of benefit. It's a Schedule 1. It's in the same category as heroin, cocaine, which is ridiculous, as we all know. And it needs to be put down. Hopefully, if it was just down a level, we could potentially study it more.
Thank you. Before the next question, one of our folks watching said to share with all of you that UL stands for Underwriters Laboratories, a safety organization that determines the safety of products. So I thought I would share that with you. Thank you. Any suggestions on how to manage hand-foot syndrome, particularly from capecitabine?
Yeah, so I give a lot of capecitabine, and I have since it came out a dozen years ago. And hand-foot syndrome is the most common side effect, and I tell every patient that the dose I put you on is not the dose you're going to stay on. I can't remember a patient. I have patients on, it's called Xeloda, for 5 years, but their dose is always changing. So the main way to manage side effects is dose modification and understanding that you can change the frequency, the dosing, the scheduling, all of it. In terms of managing topical effects, for those who don't know, hand-foot syndrome can be really problematic in terms of just function and walking, and it's a skin breakdown and redness that happens. There are products out there that have been formulated to help with some of that skin thickening. I think it's called Lindy, is a brand that actually makes products for cancer, skin products for, what is it called? Lindy Skin, that's it. And I've had patients that used it, and had some benefit. Again, no evidence that this is better than this, is just that standard moisturizing it any better, but you do have to moisturize regularly when you're on Xeloda. Spell the Xeloda? Oh, Lindi. Yep. Mm-hmm.
So we have a couple of questions about the safety of IV vitamin C. I like to ask the hard questions.
Yeah. So IV vitamin C is used, as you've heard, a lot. A lot of folks are giving it. A lot of folks are giving it without real evidence behind it in terms of dosing. It's obviously very expensive because it's not covered. It can be very expensive. There are some clinical trials that were done a couple of years ago in, I believe it was breast and maybe prostate cancer, that didn't show a benefit. There's anecdotal stories that you'll hear, and I think this sort of speaks to a lot of the integrative approaches where there's anecdotal evidence of benefit. There are currently some studies going on. For example, at Jefferson Hospital, locally to Philadelphia, their integrative department is actually doing an IV vitamin C study. I forget which disease sites. I don't think it's breast cancer, but just the idea that more evidence is needed with IV vitamin C. Is it dangerous? Well, the theory goes that if you're on chemotherapy, you kill cancer by causing oxidative damage to your cells. If you give a very high dose of a potent antioxidant, you would theoretically neutralize the effect of chemotherapy. That's the theory. I don't think it's ever really borne out in practice, but that's what you'll hear a lot about any antioxidant, not just vitamin C, antioxidants at high doses.
Thank you, Dr. Maida. Next question is, are there benefits to intermittent fasting?
There might, so again, at Jefferson, interestingly, there's some work being done on, from a radiation oncology standpoint with intermittent fasting, or fasting in general. I think it's about the definition of intermittent fasting and what that means. How long are you going without actually eating something or getting nutrition? If it's 12 hours, that's probably not too big a deal. If it's 24 hours, you can start running into other issues. Some of the benefits seem to stem from more, from making your body ketotic, which a lot of folks have heard the term ketosis. The evidence just is not there that works. So particularly in metastatic disease, where nutrition is an issue, I think fasting is probably not the best way for general health.
Okay, thank you. We have a number of questions about soy. They're all sort of around, you say that it's safe, how much of it is acceptable and safe. Does it matter the type of metastatic breast cancer that you have?
Well, so the safety issue really is only in estrogen-positive cancers, because genistein is a phytoestrogen, so theoretically stimulate estrogen-positive clones. So yeah, in estrogen-negative cancers, there really doesn't seem to be any question about it anyway, because that's not the driving force. Even in HER2-positive cancers, it's really potentially the HER2 that's driving the mutation. But the question is, in estrogen-positive, HER2-negative cancer, is it safe? And again, as I said, it really does seem to be safe in moderate quantities. I wish I could give you an exact ounce of tofu that you should have every day. But what I tell patients is, if you weren't a big proponent of edamame or tofu or soy milk, this is not necessarily the time to start doing it. But if you were somebody who did do that previously, you don't need to stop. That's my sort of very general statement about it.
Thank you. Our next question is whether CoQ10 helps protect heart function, particularly among people who might be taking medications that could affect the heart.
Yeah, so when CoQ10 came out as a supplement, its initial data, I believe, was in cardiomyopathy, which is heart failure, the term heart failure. And there were some benefits from that standpoint. Whether it protects, I guess the question is, does it protect against chemotherapy-induced heart damage? We don't know. We don't know, and I wouldn't necessarily use that as a means to believe that those drugs are safe for the heart. You should be monitored exactly like you otherwise would if you're on adriamycin, or if you're on Herceptin, you need to be followed regularly. Plus, the mechanism of Herceptin's damage to heart muscle is very different than the mechanism of adriamycin's damage to heart muscle. And CoQ10 works more in the sort of adriamycin end of the damage.
Okay, next question is, can antioxidants in food help feed the cancer rather than help eliminate it?
Yeah, I mean, I don't, other than the theory that it could, that antioxidants could prevent the benefit from treatment, I don't really believe that it would feed. This idea of feeding the cancer, I think it's important to maybe talk about that briefly, just to say that, you hear sugar feeds cancer. Well, it's not that, if it were that simple that, cancer is a little Pac-Man and eats up sugar and grows. It's not like that at all. But sugar and cancer are connected because of insulin and something called IGF-1, and so it's complicated. So I wouldn't say it's as simple as if you took a vitamin C, your cancer is going to grow. I don't think there's any evidence to support that.
Thank you for talking about the sugar, because we hear a lot of times that people feel very guilty when they have metastatic disease and they want
Having
some sugar.
any sugar, yeah, I know.
Our next question is from someone whose wife is currently going through Taxol treatment and has mouth and tongue sores. Would you recommend a good probiotic to help regulate her gut health?
Right. So mouth sores. So I guess the crux of that question is to suggest that the gut microbiome and the bacteria in the gut affect everything. And particularly if you think about what the gut is really lips to anus is your gut. So probiotics and replenishing the good bacteria in the gut that often get destroyed because of chemotherapy or whatever can help. So it's possible it could help with mouth sores, but actually curcumin has actually been shown to help with chemotherapy-associated mucositis. So that might be something that you may want to try.
Thank you. What are your thoughts on ketogenic diets?
Yeah, again, I'm not a big proponent of that. They're very complicated to do. I think nutritionally, they often cause more deprivation, so I'm not a fan.
Great, thank you. The next question is, I have HER2-positive disease. Should I stay away from all isolates?
I'm not sure what that one means.
I don't either, I'm sorry. That's why I asked the question.
Isolates, yeah, I don't know.
Okay.
Yeah, sounds like you should stay away, but I don't know. Oh, from HER2, you know what, I don't think I can comment intelligently on that. I don't know the connection.
Okay. So the next question is about the value of seeing an integrative oncologist versus seeing someone who's a traditional oncologist. Mm-hmm. And is there more value, less value? Is it worth switching?
Yeah, it's a good question. So right now, there's still this divide between an integrative physician and sort of the standard allopathic, standard trained medical oncologist. There's not a lot of folks who are doing both. I think there's value on having, so your oncologist is the first person you'll be seeing, or is the main sort of captain of the ship for your cancer care. I think there's value in having an oncologist who's open to suggestions about seeing an integrative physician, and hopefully there might be even some docs in that docs community who they work with. So I think oncologists, because a lot of oncologists this is not, how we're trained. I mean, 10 years of medical training. I think I had a 2-week course in nutrition in my 3rd year of medical school in the wintertime that no one went to. So we're just not trained in integrative practices, just even as simple as diet. So, but if we're not, having someone who's open-minded enough to say, yeah, I'll work with this person, but I need to see, then that person can then provide evidence to the oncologist and vice versa, and in a perfect world, that would work well. So seeing an integrative oncologist is actually not very easy to do. There's just not a lot of folks out there right now.
How do people find someone to work with who they can trust will be safe if they're not going to an integrative oncologist?
So you mean what integrative practitioner would be safe? So the Society of Integrative Oncology is a great resource for that. So they have a list of the board-certified practitioners who've been through the process. It's not to say that, I don't want to necessarily denigrate practitioners that might be out there that are doing great things. There's naturopaths out there that really are good and are cautious and really have some great ideas. It's just, part of it is, your center, and do they feel comfortable working with this person? There is some word of mouth to this, but be careful with word of mouth, because anecdotes, the plural of anecdotes is not data, which is unfortunately in the integrative world we're guilty of sometimes.
Well, I want to thank Dr. Mehta for his wonderful presentation, for answering so many of your questions.
Thank you, thank you.
My last time up here. Thank you so much. Remember, Dr. Mehta and 2 other authors did write a book called After Cancer Care. We do have 2 copies up here. You can get it on Amazon. I saw a lot of you taking pictures of the slides. We will make these slides available, but this book really has all that information. So also, back in November, we did a Breast Cancer 360 on integrative cancer care, and you can watch that lot. You can watch the video on our website, which is another resource. So in ending the conference, I want to thank our sponsors again. Please take a look at all of them on the program. Our work is not possible without them. I want to remind everyone we will have a date soon for next year's conference, for our metastatic conference, but we will be in Memphis in October for our annual conference, and we will have a lot of workshops for the metastatic community. We also will be training another group of Hear My Voice volunteers, so take a look for that. And we'll be up at Dana-Farber in July for a program on July 20th that really focuses on young women with breast cancer and managing side effects. That's just like a tiny bit of what we're doing, because we're doing things all the time. We will have a webinar right after the ASCO meeting, so if there are any breakthroughs with breast cancer, we'll be reporting on them. So I have to remind everyone that you have to fill out your evaluations. They'll be emailed to you. We really do read every single evaluation. We like your comments, so please take the time to do that. For those of you getting travel grant reimbursements, you can do that out in the hall. And I just want to thank everyone for being here. This is really all about you, and so it's great that you took the time to be here. Thank you.